TopMedTalk.
Hello and welcome to TopMedTalk. I'm Desiree, Chappell, your host, and we are coming to you from EBPOM 2020 live from London, our very first 100% virtual event. Now, it's been a great conference so far with amazing pre-recorded lectures from world authorities in perioperative medicine, and we had some great live panel chats with all of them as well. So if you haven't been able to tune in because you're in a different time zone or all the way around the world, stay tuned because we are playing everything 24/7. We also have some really cool entertainment and our very first ever Pockapalooza coming up. So here to tell us a little bit more about EBPOM and what's happening and joining us for this conversation is Editor-in-Chief Monty Mythen. Hello, Monty. How are you? Big day 2 of EBPOM, yeah?
Big day 2. I think I'm more relaxed today. I must admit, I found yesterday at times, we all did, stressful. I'm told that actually it was excitement that I was experiencing, but it felt like stress at the time. It's, you know, when you're putting something like this on for thousands of people, you've sort of heard about internet crashes and system crashes and all those sorts of things. And you kind of think, yeah, well, you know, we're just
that won't happen to us.
They're not living in London. And to be fair, you know, we've got a fantastic technical team here who warned us about all of this. And in reality, it only affected a few people for a short period of time. But the stress you feel for them at the time is very challenging. But we're you know, here we are, day 2, and tomorrow's our Pockapalooza. We're going around the globe.
Yep.
You'll be leading on that, starting in Cape Town, South Africa, 8 o'clock British summertime tomorrow morning, and bring us back home 24 hours later, having gone through London, Chicago, Los Angeles, Sydney, Hong Kong, or Hong Kong, Sydney, back to Cape Town. You'll have to tell me which way around we're going.
I know. It's all good. It is a 24/7, or not 24/7, but 24 hours around the world perioperative care festival. That's what Pockapalooza stands for, right, Monty?
Yeah, absolutely. And there is a T-shirt.
There is a T-shirt, so it's a real deal. It's a real deal. Well, real. Monty, it is. It's real. So going on to our next conversation here on TopMedTalk, because we, as we normally do if we were there at the conference in person, having conversations with guest speakers and key opinion leaders around the world at our booth. We are today joined by one friend of yours, actually Jim Down from UCLH there in London. Jim, thank you so much for joining us.
Pleasure. Thank you for having me.
Yeah. Well, Jim, for our viewers, can you give a little bit more about your background? What do you do there at UCLH?
So I'm an anaesthetist and intensivist at UCH, split sort of 60% to ITU and about 40% anaesthetics, although in the last few months, obviously I haven't done an anaesthetic since, well, you can imagine when. Yeah. But hoping to go back in September, everything crossed.
Yeah. I think that's a reality that we've all been dealing with, anyone that works in the OR. And I'm sorry I call it UCL, it's the University College Hospital, right? I'm always mess up. Monty teases me because I mess it up every time. Because I'm in Louisville, and so we're the University of Louisville, so I always say University College of London. Sorry.
No, I mean, it is officially University College London Hospitals, I think.
Okay.
But this building is UCH, so yeah, I messed it up more than you, probably.
That makes me feel a little bit better. Well, Jim, earlier we were able to hear from you to talk about a very important subject and very hot topic in anesthesia right now, procedural sedation. So let's go ahead and dive into that video, and when it's finished, we'll come back. We have another guest joining us, and we'll have a little bit more discussion about that.
So thank you very much indeed to Monty and Mark and the EBPOM team for inviting me to speak today. My name's Jim Downham. I'm obviously an anaesthetist and intensivist from UCLH, but I'm also the son of a gastroenterologist and mildly traumatized by a childhood in which my dad practiced a little private work from home, and there was frequently a rigid sigmoidoscope soaking in a bucket in the back outhouse. And more recently, I've been scarred by the fact that pre-COVID, I anaesthetized for an endoscopy list. And once a year, this involved a thing called London Live, in which more and more ambitious procedures were undertaken through endoscopes at UCH and beamed to a live audience, while I attempted to keep the patients at least semi-unconscious and still. And that has led to me having quite a personal interest in this subject. And really, from my perspective, it is a story of three characters: the good, the bad, and the ugly. The good is, of course, the patient. That's why we're all there. They are good. But like most good things, they have high standards and they have clear wishes. And they are clear that they do not want to know anything about the endoscopy this time after last time. And on top of that, they're complicated. Nothing good is simple. And usually they've got many comorbidities for us to consider. I'm not saying that endoscopists are bad. I am genetically half endoscopist. But they're different to what we're used to. They don't have the same relationship with scrubs as surgeons. They work in a slightly different time zone. They're more sort of Central European time than Greenwich Mean Time, if you like. They are often running a clinic while they're doing the list, and they're very happy to bleed into the afternoon. So it takes us a little bit of time to get used to each other. And they come with other staff members that we're perhaps not used to in normal theatres, and who have slightly different priorities to us. And then the ugly, it can be the result. This isn't one of my attempts at sedation for endoscopy. This is obviously a drug addict. But it is a familiar looking scene. The front crawl position, syringes strewn around the place, and a bit of vomit trickling out of the mouth. And I think the anaesthetic challenge really boils down to the fact that there is a difference between expectation and the reality of what happens in an endoscopy suite when we go to, help, I suppose, essentially. And the expectation depends on who you are. So for the endoscopist, the expectation is really that this is just a whiff of sedation. It's not an operation. There's no cutting of skin. It's not a painful thing. It's a quick look down into the stomach and a little procedure. There's absolutely no need or time, obviously, for a general anaesthetic. But of course, we've got an anaesthetist here, so this patient should be absolutely asleep and still. Patient, as I've already alluded to, is clear that they want a general anaesthetic. They don't want to know anything about it this time. And the staff basically would like us to be invisible and not to rush them. They have a lot of their own equipment. There's radiology equipment, and we really need to disappear if at all possible. And that leaves us with some expectations which don't marry up to the anaesthetic reality, which is that you have a shared airway, almost no airway as the scopes get bigger and bigger that are pushed down into the stomach. In a patient who's on their front, of course, who's unwell, sick both in the comorbid sense, but also having had air insufflated into their stomach, which wasn't emptying properly anyway, often sick in the real more physical sense. In a place where there is no space, as I've alluded to, where you're not surrounded by your mates, you're very much in a remote site, and you may well not have a trained assistant, and I'll come back to that later, but there's no a mandate that you must have a trained assistant, or indeed an anaesthetic machine. And now more and more doing something that may well take hours, 2, 3, 4 hours, as they undertake more and more complex procedures through an endoscope. And very often it can feel as if you're doing an anaesthetic under these circumstances. You're in a sealed room with someone on their front, no access to the airway, and no useful equipment. And on the London Live course, which I've been running, I have live to an audience experienced these complications. I've had someone aspirate all the way up the CO2 line to fill the trap. I've obviously had periods of apnea and desaturation, and on the other hand, people moving. We had a tension pneumoperitoneum that had to go and be emergency decompressed in the CT scanner, perforated bowel and sepsis, awareness, of course, as it's sedation, not general anaesthetic, and many discussions about the wisdom of the whole thing. So how do we get to this position? How do we come to be involved in this at all? Well, Back in the 80s and 90s, there was a study in gut showing that the 30-day mortality from a simple or from a gastroscopy was 1 in 2,000, so not an insignificant mortality. And about a third of those were attributable to inappropriate sedation. So the sedation being delivered by the endoscopists was causing problems. Not enough IV access, etc., inadequate monitoring. And even 10 years later, NCPOD's study showed that 1 in 7 patients were being inadequately sedated and 1 in 7 patients were being over-sedated. So there's a big incidence of sedation being wrong, either too much or too little. And of course, in the last 20 or 30 years, endoscopy has taken off hugely. It is like radiology, it is doing more and more and more. But that doesn't, and which has meant that more complex things are done and more patients are suffering as a result. And more recently, a study showed that 40% of patients after an ERCP describe pain and discomfort, and 1 in 10 actually describe severe mental health problems after sedated ERCP. So this is having a significant impact on the patients undergoing these procedures. And it became clear that we needed both safer sedation and deeper sedation in order to reduce the risks and improve the patient's experiences and outcomes. And of course, luckily, we have a drug that is well suited to that, Propofol, but unluckily for the sedationists, traditionally Propofol has only been administered by anaesthetists, and that means that the whole combination is extremely expensive. And when you multiply that up by the 1.5 million endoscopies done per year, and this is a couple of years old, so it may be more now, it's an extremely resource-hungry procedure. And this has led to a worldwide debate. And the debate is whether Propofol and anaesthetists need to be a unified item, or whether you can have the Propofol without the anaesthetist. And around the world, this has raged to the extent that in 2009, this group decided they would answer it once and for all. And they phoned up everyone they knew who was delivering Propofol by non-anaesthetists and asked them for all their figures. And they came up with 646,000 cases. Now, not all these are published, but they claim that 646,000 cases are recorded without anaesthetists with Propofol for endoscopy, and only required 11 intubations. No neurological damage, four deaths, but they were in people who had terminal disease anyway, and very low rate of mask ventilation. And you can feel the passion, if you like, in this paper, particularly when they report that even if the anaesthetist had saved all 4 deaths, that would be at a cost of £5.3 million per life saved by an anaesthetist. So similar to the cost of going to the Nightingale Hospital. And this wasn't just one group of fanatics. The European Society, shortly after this, published guidelines recommending a way that anaesthetists could be delivered by Propofol could be delivered by non-anaesthetists for endoscopy. And this was based on the fact that in Germany and in Scandinavia particularly, they had good series of patients showing safe and good outcomes with Propofol from non-anaesthetists. So this is a publication of 24,500 patients in Germany, and what they did was they used non-anaesthetists administered Propofol for simple procedures in well-screened, well patients with just an endoscopist and a nurse and protocolized care. And their protocolized care was that they'd get 30 to 50 milligram boluses of Propofol, aiming for moderate to deep sedation, and then 20 to 30 milligrams top up. And they really show a very good safety profile. So major adverse events, 3 apneas and a laryngospasm, but that's a rate of 0.016%. And even minor adverse events only come out at about 0.5%. So this seems a very solid, safe way to deliver Propofol. And in Scandinavia, they go on to report doing more complex procedures with propofol by non-anaesthetists. So this is a study of 1,900 nurse-administered sedation with propofol for people having ERCPs, EUSs, more prolonged, sort of half-hour procedures, but again, very carefully picked. So these are elective cases, well patients, non-obese, well-screened, straightforward airways, and very protocolized care. So their protocol was that you'd receive 100 milligrams of propofol minus your age. So if you were 90, you'd receive 10 milligrams of propofol. If you were 50, you'd receive 50 milligrams of propofol. And then half that dose to maintain until you stopped responding to verbal or light tactile stimulation. And then 10 to 20 milligrams if required for discomfort. And the extraordinary thing about this is that the training to deliver this was 2.5-day course plus 4 weeks of supervised work. So a very short amount of training to deliver propofol apparently safely to well-screened patients. And their outcomes were very favorable as well. But of course, we all know of stories where propofol delivered in remote sites by non-anaesthetists has fatal consequences. And there was still a big debate raging through the anaesthetic and endoscopy community about the wisdom of delivering a non-reversible drug that has a narrow therapeutic window by non-anaesthetically trained people. And this study from Australia does make you sit up and think. So this is a study of 2,100 consecutive patients who came for endoscopy, both elective and emergency, all sedated with propofol pretty much by anaesthetists. And they show a very different profile. So they're showing unplanned event rates of 23% and a mortality of 1.26%. And of course, part of this, or perhaps all of it, is explained by the fact that their patients are much sicker, lots of ASA 3 and 4 patients, lots of emergency patients, and complex procedures. But of course, there may also be the fact that this is sedation done by anaesthetists, and it's possible that anaesthetists tend to anaesthetize, i.e. sedate more heavily than sedationists who are following strict protocols and can only sedate. And that's something I think we need to keep mindful of when we go through the debate. However, although the European societies were suggesting that non-anaesthetists administered propofol was safe and should be done, the individual societies, the national societies who met in Europe went directly against this. In 2011 said absolutely not. Only anaesthetists should administer propofol for procedural sedation. So the debate was far from resolved. While on the other extreme in Scandinavia, they'd gone as far as letting the patients deliver their own propofol in a sort of patient-controlled propofol regime. And they published good results with that. So this is a study of nearly 300 patients divided into those where they had patient-controlled sedation with 5 milligram boluses of propofol, no lockout needed as they fell asleep when they'd had enough, versus non-anaesthetist delivered propofol versus conscious sedation, i.e. midazolam and fentanyl. And what they essentially showed was the patient-controlled sedation used less propofol than the nurse-administered propofol, had fewer respiratory events, woke up more quickly, but it was also effective. So the vast majority of procedures were completed, far more than completed with conscious sedation, and the satisfaction was as good between patient-controlled sedation as it was with nurse-administered sedation. So it seems, and this is obviously early days for this, that you can actually get patients to deliver 5 milligram boluses themselves safely and effectively. They did have sedationists present, so it doesn't yet save us money. So what's going on in the UK? Where are we with this whole story over here? I've talked a lot about Europe, a bit about the States. What about over here? Well, I think us entering the endoscopy suite has been beneficial and has been perceived to be beneficial by the by the endoscopists themselves. They do see these benefits. They are very pleased that they are now not hamstrung by their maximum doses of 100 mics of fentanyl and 3 mg of midazolam. They've embraced 2 checklists in my experience. This has been something that we probably took down there and they've grabbed and now appreciate. They love the fact that the airway is now not a concern of theirs and it's safe and our responsibility. And they don't have to multitask. And they have a patient who is still, or stiller perhaps, than they're used to. And they have their nurse back. They don't need to donate a nurse to the head end, if you like. They can concentrate on the endoscopy. And they're very aware that patient satisfaction has improved with this. And this is borne out by a study from UCH, where we looked at both comfort scores and awareness scores. And in the grey, you've got fentanyl midazolam, sort of conscious sedation, if you like. And in the black, you've got Propofol/GA, i.e. anaesthetist-administered sedation. And clearly in both scores, the anaesthetist-administered sedation hugely outperforms the patient, conscious sedation. On the other hand, it hasn't always been a smooth road. There are definitely areas where there is friction bringing anaesthetists into the endoscopy suite. They're not, in my experience, massive fans of our pre-assessment clinics. I think they think that slows things down and we get caught up in bureaucracy and MRSA swabs. Our obsession with the notes, obviously for us that's gone away because we've now got an electronic record, but our insistence on the notes for someone who's travelled 400 miles causes some angst. There's a perception that perhaps we can slow down lists, we slow down turnaround, we start late, etc., etc. And of course, I think there is a problem with inconsistency. So if this isn't somewhere you're used to working, endoscopy is a bit of a shock to an anaesthetist. They can be outside their comfort zones. And if endoscopists get a different anaesthetist every week, it can be quite distracting to the list, if you like, and cause some bumps in the road. And the final thing to say is, of course, that's my experience, but around the country, there's huge variation in what is offered in terms of anaesthesia to endoscopy lists, from no endoscopy lists having anaesthetists to 100% of endoscopy lists having anaesthetists. And of course, I think that we have to be mindful, as I sort of mentioned earlier, as to are we as good as we think we are at sedating people? Is it possible that we're better at anaesthetizing than we are at sedating? And actually, if we went back to more protocolized sedation, we might improve our practice for this particular procedure. So how do we find a way forward? How do we deal with this impasse, if you like, that's safe and cost-effective? Well, and why is there such a disconnect, apparently, between what we're doing here and what they're doing in Europe, particularly, and in parts of the States and other places around the world? Well, this is something that's been wrestled with by our national body. The Royal College of Anaesthetists and the British Society of Gastroenterologists published a paper looking at the use of Propofol in ERCP in 2014, and they came up with some recommendations. And they acknowledged that around the world, non-anaesthetist administered Propofol was used widely and safely. But in this country, there wasn't nationally recognised formal training, so we should stick to it either being an anaesthetist or a supervised PAA, i.e. this was essentially like a general anaesthetic list in terms of the cover that they recommended we gave. They also recommended that there should be pre-assessment, full pre-assessment for everyone, that ideally you should use Propofol alone, not a mixture of Propofol and opioids. There should be piped oxygen and suction, but an anaesthetic machine and an ODP in the room was not essential. And then there should be monitoring ECG, blood pressure, and skilled staff. I'm happy with these guidelines in terms of the safety, except for this one aspect in the middle. It feels to me this is like sending a soldier into battle who's fully trained but hasn't got a gun. I think I think if you're going to mandate an anaesthetist should be there and it should be treated as a general anaesthetic list in all other ways, then you must mandate that there is an ODP and an anaesthetic machine. And having said that, I'm pleased to say that a new guideline that's come from the British Society of Gastroenterologists and the Royal College of Anaesthetists has actually changed that position a little bit. So this guideline went into the whole issue of endoscopy and propofol in a bit more detail, and they came up with guidelines relating to the type of procedure as well as the type of patient. So they suggested that anaesthetist-led, i.e. anaesthetist-led propofol, deep sedation or general anaesthetic should be considered for these more complex procedures. And this makes perfect sense to me. These are more lengthy, more complex and more potentially painful procedures, and they need proper deep sedation or often a general anaesthetic. They went on to say that the patients needed to be screened carefully and if they had significant comorbidities, significant airway concerns, OSA or previous poor tolerance of endoscopy, then those were other patient indications for anaesthetist-delivered sedation. And that if you are delivering deep sedation, you should have an ODP, a trained assistant in other words, and an anaesthetic machine and pre-assessment clinics. And again, I can't argue with this from a safety point of view. I think this is good guidance, it's safe, but it does still state that all propofol needs to be delivered by anaesthetists. And perhaps here, I think we're still missing a trick in this country. So what do I think we're missing? Well, I think you can divide up endoscopies from our perspective into categories. There's a quick scope. Someone having a top-end gastroscopy really doesn't need sedation at all necessarily, maybe a bit of throat spray. When I had my endoscopy for hypochondria, I just had a bit of throat spray, no sedation at all, and it's a very quick procedure. It was a bit unpleasant, but it was fine. If anything, a bit of fentanyl midazolam will be fine for the majority of people. Same for the bottom end. Again, doable with no sedation, but if not, perhaps a little bit of midazolam or a little bit of nitrous oxide is usually, for most people, plenty. At the other end of the spectrum, I think there are long, complex procedures that always need an anaesthetist. These always need ongoing, deeper sedation for up to 2, 3, 4 hours. And probably most of these actually need a general anaesthetic as they get more complex and more in depth. But between these two extremes, if you like, of sedation, for me there is a twilight zone. And it's this twilight zone where perhaps we should explore the use of sedation teams, i.e. trained sedationists, non-anaesthetists, who can give more than a bit of fentanyl midazolam and can give some propofol by a protocol as they do in Germany and the Netherlands. And I'm talking here about low-risk patients who don't tolerate conscious sedation, so people who have had an endoscopy with conscious sedation, it's been unsuccessful, they need more, but they've no other comorbidities, so they can have, they could do it with a sedationist and some propofol. Or people who are having a moderately complex procedure but are also fit and well and need just a bit more than fentanyl midazolam to get through that procedure. And I think that's an area where we could easily consider sedation teams and where there's good evidence, I think, from around Europe and around the rest of the world it can be delivered safely and these patients can be screened out successfully. So where have I got to in conclusion in this whole story of sedation for endoscopy and potentially, of course, for other interventions? I think we need to screen our patients. I think high-risk patients, both procedurally and patient factors, need to be drawn out, and those should be looked after by anaesthetists. Then I think we can divide up our patients into 3 groups. A quick scope in a well patient, just conscious sedation. A high-risk patient or a very long procedure, I think, needs an anaesthetist and full equipment to deliver a general anaesthetic or deep sedation. But low-risk patients and people having moderate procedures without alarm bells, I think, can be safely sedated with sedation teams by protocolized care. I also think we have to be mindful that as anaesthetists, we tend to anesthetize, and perhaps we give more sedation than is absolutely necessary for these procedures on occasion, and that might not be optimal care, although I appreciate I'll get shot down for that. I think there's a potential that sedationists who are protocolized and can only sedate, will only sedate, and with a training program and tried and trusted protocols, they can do that safely and effectively. I think there's a real potential that in the future we might even let patients take control as we get more data on this. I think it's certainly something we should keep in the back of our minds, although not yet. And on another subject that I haven't touched on really, I think we have to start consenting people for awareness if we're not giving them a general anaesthetic. And I think if people are adamant that they do not want to be aware, then we have to give them a general anaesthetic. And I think then there's more work to be done. I think there's an interesting studies been on high and low dose propofol and the effectiveness and the complication rates of those two. And of course, whether anaesthetists or non-anaesthetists deliver it better. And that's really where I've got to. So hopefully in the future this will be explored more, and perhaps in this country we'll start to explore alternative practice. Thank you very much.
Well, Jim, thank you so much for that fantastic presentation on procedural sedation. There's a lot of issues and things that you discussed there, so we'll do a deep dive here in just a moment. Now, I'd like to introduce another guest that's joining us today from Cambridge, Amit Prakash. Amit, thank you so much for joining us.
Thank you for having me.
For our listeners and our viewers, Amit, can you please tell us a little bit more about yourself?
So yeah, I'm a consultant in anesthetics. My subspecialty is primarily neuroanesthesia. So that's what I do as a day job. Now, in terms of this specific talk, in terms of sedation, I have been involved with various aspects of it since around 2010, and I work with sedation leads in all other subspecialties, so gastroenterology, respiratory medicine, interventional cardiology, interventional radiology, and we have a committee, and I'm chair for that sedation committee at Cambridge University Hospitals in Addenbrookes. So it has been one of my interests, and I'm involved in teaching, and we've recently undertaken a sort of a service evaluation with some objectives. So yeah, very, very interested in what Jim just said, and yeah, looking forward to a good discussion.
Yeah. Well, Jim, just to revisit some of the things that you discussed in your presentation, tell us a little bit about the difference between procedural sedation and anesthesia and how all that's working currently in the UK.
Yeah, so I think, I suppose the key reason for this becoming such a big topic is that more and more is done outside of the operating theatre now by non-surgeons, if you like. So more and more interventions are radiological, gastroenterological, or respiratory, and minimally invasive, and therefore potentially not needing a formal general anaesthetic. On the other hand, as these procedures get more complex, the sort of classic conscious sedation that perhaps the ologists themselves could deliver is often not enough. And what we've found is that there is this middle ground where Propofol as an agent seems to work well to give a deeper sedation without giving a full anaesthetic, if you like. The question then becomes who delivers that, and obviously, as I talked about, that's culturally very different in different places around the world. And I suppose the two reasons that people are nervous about it are, one, the narrow therapeutic window, and two, the lack of a reversal. And so it's ended up in this difficult sort of place with a lot of publicity, you know, obviously the Michael Jackson thing, that kind of thing, and people getting very much divided into camps. And really what I was exploring, I suppose, is whether there's a place for those two camps to meet, if you like.
And Jim, you touched on it in your talk. The boundaries, they always seem very blurred. When is deep sedation with propofol not an anaesthetic?
So I think that gets to the heart of the problem, doesn't it? I mean, there are definitions of what deep sedation is, but of course, the way people talk about it is often as a general anaesthetic. And a great example in endoscopy is the patient. The patient who's having deep sedation in endoscopy is often having it because they had light sedation last time and they don't want to know anything about it this time. And so you're in they're sold it as a general anaesthetic, if you like. But of course, it's not a general anaesthetic, and really we should be. I think we should be upfront about that and acknowledge that they may be aware, because you're not giving them a formal anaesthetic. You're giving a deeper anaesthetic, at which they are rousable to persistent touch, if you like. So it's not. I think we have to be wary of that. The creep in definition.
So can I just say this is really interesting, and this is what I found out by speaking to the colleagues who are non-anaesthetists, obviously, and all of my work has been with non-anaesthetists. And what I have found with sedation is that even if we do it as anaesthetists, we delve into a deeper depth of in sedation. The reason why we don't feel stressed about it is because we have excellent monitoring, and that we are trained in managing airways and all the other complications related to sedation. And I have felt that this is where I think the non-anaesthetists, that there's a little gap there where we can introduce further monitoring and also perhaps a little bit more training, because what I found with capnography especially was that although it was a great idea, and obviously our association as well as the American Heart Association and a number of very important associations have propounded this as the way to go with monitoring, but there's no uptake of that because of lack of education around it. Because if you look at nurses or sedationists who are doing sedation with supervision from the clinicians, there is that hesitancy because there is a white line on the screen which they do not understand, and to introduce that and to spend all that investment into that sort of monitoring without understanding something is not something that most of the departments are prepared to do.
So my understanding then is that there are other people that do deliver sedation. It's typically not propofol, but do they have any other formal training in sedation or certification or anything like that in the UK? Jim?
So I know that I think each of the societies, the British Society of Gastroenterology, the Radiology Society, they all have included sedation now into their curriculum. So and this is something that they're looking at. There is a section on it, but in terms of CPDs, I think the best evidence comes from the Academy of Royal Medical Colleges document from 2013, where they have suggested that people have sort of some regular CPD around it. We feel in our hospital, this is what we have been going by, that about every 5 years you should have a certain number of CPD points to make sure that you are getting enough training and experience in sedation. But I mean, we have been very fortunate actually in Cambridge, because the safe sedation course, which is meant for clinicians, the junior trainees in these specialties that I just mentioned, that has been taken on by the dean, and we have funding for it. So it is free for the trainees to come and not free, but it is supported by the deanery to come and attend that course, which is a simulation-based multidisciplinary course which we run twice a year.
Yeah.
I mean, I have a suspicion that sedationists, i.e. non-anaesthetists, would actually probably deliver better sedation in a way. And that's a slightly heretical thing to say, but I think one of the problems with anaesthetists going and delivering these deep sedations is that they're anaesthetists, and therefore they sort of feel they failed if they haven't given an anaesthetic. I mean, that's not quite true, but you know what I mean. If the patient moves or something, then that is a sort of not a good event. Whereas a sedationist who can only sedate, I think from what I read from what they're doing in Germany and Scandinavia, if you pick the right patients and you put them on tight protocols, because they can only do that, they actually deliver a very safe service. It doesn't get every single person through a procedure, but it does seem to be safe and get an awful lot of them through. So I wonder if they might do it differently and possibly, just as effectively, if you like.
Yeah, that's such a great point. So, I'm sorry to interrupt you, Jim.
No, go for it. No.
I was going to say, it's a great point. In the U.S., I'm a CRNA, a nurse anaesthetist, if you will, and I do a lot of sedation. We've taken over the GI suites, and, we're venturing into cath labs all over the place. And, we call them room air generals because that's what they end up being, because it's a general anesthetic because we keep them so deep. And I think you're right. I think we tend to do that because we're used to doing monitored anesthesia care that has really crept into more of general anesthetic zone because the doctor doesn't want to remove, or you're trying to get away with a procedure where you don't want to give them a full general, but but you don't want to just do a conscious sedation kind of thing. I mean, I think you're totally right about that. Sedation nurses, those that I've seen, and especially in our GI suites, they do a great job. But what's happened is that because there's not a standard of care, and there's not necessarily, they don't understand capnography, that, now we have chronic pain patients, we have patients with extreme comorbidities that they're trying to get away with it. And if they're not doing this monitoring, it really it's dangerous. I mean, we have had to step in a lot with codes with over-sedation, with fentanyl and narcotic usage, and, Versed that just lasts forever and they never can get enough. And we know how easy it is to kind of tip over the edge. So have you guys worked there in the UK? And Amit, you've done a lot of work in this too, for standards of care, standards of monitoring, anything like that?
Yeah, so I think some of this is translated from anesthesia. So the minimal monitoring standards, which is saturation, blood pressure, ECG, those things have been more or less being used in all of the non-anesthetic practice. There is variability there in the UK especially, but it has been used. And in fact, in our hospital, there was sporadic use of capnography as well. So they have been used, and what we're trying to do is to say that capnography should also be a minimal monitoring standard. The issue, like I alluded to earlier on, is just the fact of education around it and who's doing it, like Jim and you just mentioned. We do have dedicated sedationists, but not at our hospital. It's primarily senior nurses who take on this role, or some of them who like to get involved with this. And for them, again, education has been an issue. So I'm not trying to be too big-headed or anything, but we do have another course which is for the nurses, which is called Monitoring for Procedural Sedation course, which we run because we realized that was a gap. But these are the 4 monitors which I think we have been trying to institute across.
At the moment, you refer to the fact that there are guidelines, but is this very much sort of the standards are sort of set internally and self-governed at the moment? Is that one of the things that possibly needs addressing? Is it doesn't sit within a college structure, or it doesn't necessarily have a recognised professional qualification? Are we in a grey zone at the moment?
So there is a. Sorry. No, go. I mean, there is a joint document from the Royal College of Anaesthetists and the gastroenterologists about it. And what's interesting about it, the original one from 2013 was really struck me as highlighting the problem, because it said you need an anaesthetist to give propofol, but you didn't need an anaesthetic machine. And I was thinking, hang on, what are we saying here? This is you can need a soldier, but they can't have a gun, sort of thing. And that's changed now to saying you need an anaesthetist and full equipment and a trained assistant. And they also acknowledge the fact that in other countries it's done safely with non-anaesthetist administered propofol. But the line in that document is that there isn't a recognised training program in this country yet, and that is one of the reasons why we're not doing it that way. So I think that there is some national guidance, but I think there's still an area that we haven't sort of grappled with. I mean, maybe Amit has something to...
And Jim, before we go back to Amit, would you go that extra step now? Because it feels to me as though things are usually safer and better if you embrace it and identify it as a profession or a professional, an extension of a profession, and have some clearly set standards and guidelines and qualifications.
Yeah,
I think in my mind that there is a little bit of a grey zone, and what Jim says is absolutely correct, which is that the British Society of Gastroenterologists have produced a joint statement. It needs to be all the other areas in the hospital where sedation is being practiced that needs to come under the same umbrella. There needs to be coherence between these silos of practice around. And the more I do this sort of the committee work, the more I've realized that there are even hematologists who are giving quite a lot of sedation for things like biopsies and things which we did not know about before. So there's a lot of gray areas in here, and in terms of laying down minimal monitoring standards, laying down the qualifications perhaps, or identifying people who are qualified to do sedation would be a step forward for sure.
Great. And Jim, did you want to comment on that?
No, I think I'd agree. I think, what's slightly interesting is I then tried to speak to some Europeans about it, and I couldn't quite find the people who were doing exactly what was written in the papers. But maybe that's my just lack of looking. So it seemed that actually they were doing, what we call AAs, more those type of figures under supervision.
And sorry to interrupt, Jim. An AA?
Anaesthetic associate. So I suppose the equivalent of a nurse anaesthetist in the States. So who would do a GA list with some distant supervision in this country. So it wasn't what I was reading in the papers where these were nurses who did a short course in propofol sedation. But perhaps I haven't looked hard enough.
Well, if there's anyone out there listening from those countries that are doing protocolized, please let us know. We'd love to chat with you. We can set that call up. Well, Amit, can you talk about some of the outcomes work that you've been doing and looking at when it comes to procedural sedation and utilization of capnography and some of this other monitoring standards?
Yeah, so this was essentially taken on as a quality improvement project. So this was registered as a service evaluation of practice in 4 departments. So it was respiratory medicine, gastroenterology, cardiology, and interventional radiology. So we took leaders from these 4 areas, and the idea was to essentially see what is the current practice and then see whether we could introduce capnography, and if we did, then does that make any difference? Now, in my mind, it was very clear right from the beginning that there's going to be a huge benefit in using capnography. But I had an ulterior motive around this, and I knew that if I introduce capnography in departments like this, then they would get familiarized because they will get educated around it, they will be using it, so there will be familiarity and therefore more uptake on using of this technology. And I could not do it single-handedly, so this was obviously the leaders in these 4 areas, but also Medtronic, which were instrumental, and for us it was a perfect example of value-based, essentially, care. From association with them. The idea was to have 2 arms in there. So one without use of any capnography, we recorded the untoward events, and then we looked at introduction of capnography. It took quite a while, so we started in 2017 and I think finished only in 2019 and that was just because we found repeatedly that if a nurse specialist or somebody left, then all of a sudden the whole project sort of came to a stopper because people did not know, what to do.
Yeah. Amit, what time out real quick. I have to let Monty know, he probably already knows, that he is due back on the main stage in just a minute. So we're going to say goodbye to him, but I definitely want to finish our conversation. So Monty, any final words?
My apologies for dipping out at this stage. I think it's a really, really important area.
Yeah.
And I'm sorry to have to leave you, but they're screaming at me to go back to the main stage. So thanks for joining in. Good. And you stay where you are with Desiree. I'll see you all soon.
We'll finish it out. Thanks, Monty.
Thank you, bro.
All right. So where were you? I'm so sorry, Amit.
So essentially, we had we took these 4 areas and we looked at practice with capnography and without capnography, and recorded the untoward events, which were based on the SIVA adverse events, the Society of Intravenous Anaesthesia Adverse Events reporting tool. And we had some really interesting findings. We expected that there would be a huge benefit, but it surpassed our expectations how much benefit there actually was in using capnography. In addition to that, one of the things which I've always thought about is that, especially in the National Health Service with the fundings and with sort of bringing in new technology investments and the rest of it, the financial aspect is very, very important. And using technology like this indiscriminately may not be something that we would want to do. So one of my objectives around this was to identify perhaps procedures in these 4 subspecialties to see whether there were any procedures which we should definitely recommend using capnography. And fortunately, we had really good data, and that is all in a manuscript which we are sort of about to publish.
Great. Well, we look forward to that. Absolutely. Well, we have to wrap up here shortly, guys. But my last question, and Jim, maybe if you could take this first, is, when it comes to monitoring, when it comes to whoever is doing this sedation, and the equipment that we have and the parameters that we're looking at, one common thing is that the patients wearing oxygen, they may not be desaturating necessarily, but their CO2 is rising, and they could be, getting into trouble. We need to think about that. So not to do a deep dive into the science, but just can you address that very quickly?
Yeah, sure. No, I think that's right. I mean, I think desaturation is a late sign, isn't it? And I think we're all very attuned to capnography as a very early sign of trouble. And I mean, I refuse to do these lists without capnography. I think it's essential, just as it is in the operating theatre. So, I'm not saying that every person who has any sedation should have capnography, but I think the work Amit's doing is absolutely vital. As we do more and more and deeper sedation, then it should become standard of care for that in my book.
Absolutely. And I don't know, I would assume that it's similar for you guys, but the patients that we see now, I mean, so many more have these long lists of comorbidities and, the rate of obesity, and we know the risk for obstructive sleep apnea and all these other things. I would assume you guys are dealing with that in the UK as well.
Yeah, and one of the interesting comments from one of our gastroenterologists was, and I mean, it's not in the manuscript, obviously, but the point was that he was able to take more and more complex procedures because of the monitoring. And that I found really interesting because he was able to maintain sedation for a longer period of time. And Jim, I'm talking about this happening without any anaesthetist in the room because of the confidence on the fact that they're spontaneously breathing, that they can see the entitled CO2, that the saturations are okay, and there's a comfort level which they achieved, especially in the capnography arm, which was very interesting.
Yeah.
And I think the other point about, sometimes these people have been are having non-surgical interventions because they're sick and they're not fit, so they may be the sicker end of the spectrum. So I absolutely agree. You have to take them seriously and monitor them closely because that might be why they're there. They might be the high-risk people.
Absolutely. Absolutely. Well, gentlemen, thank you so much for this fascinating conversation. I definitely hope that we can talk about this in the future as we see more and more, things come online. And definitely, Amit, after some of this published work that you have coming out, hopefully sooner rather than later. And we can further this conversation. So it all started, Jim, whenever we really wanted to do this from hearing you at Dingle this last year. Your presentation there, we're like, oh my gosh, this is amazing. It's really interesting actually to compare and contrast with the US as well. So great presentation. Thank you so much for taking the time to deliver that for us today. Yes, and Amit, thank you for joining us from Cambridge. Thanks to everyone for listening so much to Top Med Talk during EBPOM live from London 2020. This amazing virtual experience. A lot more to come. Stay tuned. Please check the expo map for all the different tents. Check all of our sponsors. The poster sessions are absolutely amazing. Please do check those out. And then our upcoming Pockapalooza, get more information there. And we are doing a fundraising for the African Perioperative Research Group, which is very, very important. So please check that out. And TopMedTalk.com for all the conversations coming out here from EBPOM and on the TopMedTalk Zone. Thanks for listening, and we will see you again in a couple hours.
TopMed Talk.